Welcome to this concise video log on caring for an aging transgender woman with HIV. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and ViiV Healthcare. This vlog was recorded by Dr. Howard Grossman. Please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Dr. Howard Grossman, Medical Director at Midway Specialty Care in Wilton Manors, Florida, and a Clinical Affiliate Assistant Professor at the Charles E. Schmidt College of Medicine of Florida Atlantic University. I just saw a patient who represents a challenging type of case I often encounter, and I'm going to go through some of the details of this patient. Jack T is a new patient to me. He's a 55-year-old man who presented today to transfer his HIV care from another office. According to records he brings, Jack acquired HIV in 2006 from heterosexual sex with a female sex worker. His CD4 count at the time was 350 cells per cubic millimeter, and his initial viral load was about 50,000 copies. Jack was started on efavirenz 3-TC and tenofovir disoproxil fumarate. Due to nightmares and fatigue, he was later switched to boosted atazanavir plus abacavir and 3-TC. His viral load's been suppressed since then, but he wants to switch because his doctor told him to stay on meds because if, quote, if it's not broke, don't fix it, unquote. So at this present time, Jack's CD4 count is 560. His HIV viral load is less than 20 detected. Genotype back in 2007 showed no resistance. His BMI is 35. CBC's normal fasting glucose is 150 with a hemoglobin A1C of 6.2. Hepatitis B and C are both negative. His HLA-B5701 is negative, as you would assume since he's on abacavir. And other medications he's on include losartan, omega-3 fatty acids, and multivitamins. At first, Jack told me he was switching because he wanted to go on a newer single-dose regimen, but his doctor would, again, never discuss them. If it's not broke, don't fix it. On further discussion, Jack suddenly stopped the conversation to report that he's actually transgender, goes by the name Jasmine, prefers female pronouns, and came today because she wants to start gender affirmation hormone therapy, or GAHT. And for that reason was referred to us. Jasmine told me that she actually felt like a woman her whole life and began dressing as a woman in secret as a teenager. She married and had children in order to try to conform. Her wife was aware she liked to cross-dress, but she thought it was a fetish and did not realize that Jasmine was transgender. Jasmine began experimenting with sex with men in her 30s, not sure if she was gay or bisexual, but later also dressed as a woman. She rarely used condoms because she thought her partners were clean, in her words. And that is how she acquired HIV. She never told her doctor this. Her doctor never took a full sexual history, never inquired about gender identity, and aside from blood tests and urine, when she first tested HIV positive, she's never had any testing for STDs. Jasmine was never part of the LGBTQ community and had little education about the issues around transgender health. But she's been seeing more online in the last 5 years and finally reached out to a local organization that provides mental health services and counseling for transgender people. She learned about hormone therapy and she wishes to start it. So there's a number of issues related to gender-affirming hormone therapy in the presence of HIV and especially in older transgender women that we really should discuss. Number one is concern from the patient's point of view and from my point of view as a provider about drug-drug interactions. Cardiovascular disease, cancer risk, bone density considerations, primary care issues, and lifestyle considerations are all very important as we seek to initiate this important therapy. So again, the most important consideration for many gender nonconforming people and transgender people is the effect of their antiretroviral medication on their hormone therapy. I mean, truthfully, the most important thing to them is the affirmation of their gender, and anything that might interfere with that is a huge concern. To date, unfortunately, all studies that look at estradiol in cis women and trans men were focused on oral contraceptives and ethinyl estradiol. There's no clear data on estradiol valerate or cypionate or the topical preparations. Now, this slide shows you a study that was done by Dr. Radix and company and reported in 2016. In that study, they found, reviewing all the data that was available, that finasteride had no effect on antiretroviral therapy, but that levels of finasteride, which may be used to block testosterone, may decrease when co-administered with etravirine, efavirenz, or nevirapine. Spironolactone has no relevant drug-drug interactions with antiretroviral drugs, and that's really important because spironolactone is the main drug that we use to suppress testosterone as an anti-androgen. It's important to remain vigilant about new interactions that may be found. Other drugs at that time were not found to interact with antiretroviral therapy. The next slide actually is from the University of Liverpool and should serve as a good reference for you for looking at drug-drug interactions. You can see that most antiretroviral drugs, most of the nucleosides, as well as a number of non-nukes and some of the proteases, don't have significant interactions. It's predicted that some drugs may inhibit the metabolism and increase the levels of estradiol and some of the other drugs that we use. And you can see here that it's recommended that doses be adjusted with things like unboosted atazanavir, as well as drugs with cobicistat. And then there are other drugs, HIV drugs, that are predicted to interfere with the metabolism of the estrogens. And so we may need to increase our dose of estradiol to get the desired effect for gender affirmation. And so this is a very useful slide for helping us to adjust our medications to get the outcomes we want without significant side effects. There are very few things that are recommended not to be co-administered. Looking at cardiovascular risk is a complex thing. This is one study from Partners Healthcare System HIV database in Boston looking at the risk of cardiovascular disease in transgender women. And you can see it was very small, 23 transgender women with HIV and 92 cisgender men with HIV were matched according to sex assigned at birth, age and birth year, and race. The only significant differences were found to be in the level of anemia between these two groups. They were matched as far as diabetes, hyperlipidemia, hypertension, current antiretroviral therapy, and HCV co-infection. Studies on transgender men have actually shown no increased cardiovascular risk from the administration of testosterone therapy, but the outcomes are mixed, and many show no increase compared to cis men. Studies on transgender women also very mixed results. Many of them did not control for smoking, diabetes, or obesity, and that of course has a big impact on the outcomes. There are a number of concerns about possible risks of increased risk for transgender women for cardiovascular disease that include less HIV suppression, leading to increased immune activation, and that has to do with drug interactions and also with, again, the focus of many transgender women on their hormone therapy, not necessarily their HIV therapy. More anemia, as we saw in the last study, an increased rate of diabetes. Now, studies of estrogen used in cis women show decreased insulin levels and increased insulin resistance, and we believe that some of that may happen in transgender women as well. More hepatitis C in this population with immune activation, higher rates of obesity, and lack of focused primary care for this patient population, higher rates of smoking, less physical activity, and increased risks of thromboembolism from the estrogen therapies. When we look at cancer risk for transgender women on gender-affirming hormone therapy, the largest study to date found no increase in observed total cancer mortality in male to female transsexuals versus the general population. There was an elevated risk of lung and hematologic cancers, but this was not controlled for smoking and other risk factors, so it's unclear what it means. Rates of prostate cancer are not really defined, but some have been documented, and regular screening for prostate cancer is recommended. Breast cancer rates are also increased in transgender women. One study reported a 46-fold increase compared with cisgender men, but it was still less than cis women. And so cancer screening for breast cancer is also important for our transgender women. Bone density issues are another concern. Low bone density for trans women has been noted both before and after gender-affirming hormone therapy initiation. There is concern that there might be lower vitamin D because of dietary problems and higher parathyroid hormone, lower calcium intake below the minimum daily recommendation, and again, less physical activity. There are positive changes in bone density with the initiation of estrogen therapy. And so the big question is, should we initiate baseline DEXAs earlier in our transgender women? And the answer is probably yes. That is probably, if risk factors are there, probably makes sense to get bone density examinations before starting hormone therapy and then to follow them at least yearly or so as we move along, depending on the level of risk. So what's our considerations for Jasmine T? First of all, I think we want to reassure her that most antiretroviral therapy will not interfere with her gender-affirming hormone therapy. We probably want to stop the atazanavir as one of the only drugs that may have an impact. We may want to stop abacavir because she has already an increased risk of cardiovascular disease, and we may want to avoid that risk. We may want to avoid other boosted PIs, especially with cobicistat because of interactions with hormones, as well as stopping PIs because of her already high triglycerides. We probably want to initiate therapy with an integrase inhibitor or doravirine. We may want to avoid the tenofovir disoproxil fumarate due to bone density issues. That's a soft recommendation. We need to watch for weight gain with tenofovir alafenamide, but this probably is more indicated because of the bone density issues. We can add lamivudine or emtricitabine because there's no evidence of any resistance. We want to watch her hemoglobin A1C after we start gender-affirming hormone therapy. The patient already has impaired fasting glucose with an A1C of 6.2, and we need to watch that because we may get an increase in insulin resistance. Baseline DEXA, probably indicated for this woman who's over 50. Encourage weight loss to improve outcomes, and smoking cessation. Very, very, very important for decreasing all the risks we talked about. Thank you for listening today. Hopefully this helps you to treat patients like Jasmine in the future.